So the next workshop will be an interesting workshop. We've divided into 5 sessions. So first, the speakers. Dr. Binayak Sinha, sir. He's a senior diabetologist, Manipal Hospital, Salt Lake.
Give a big hand to Binayak. He was in some problem in his feet and still there's waterlogging in front of his house. Yeah. But still he came. So give a big round of applause to Binayak.
Sir, Dr. K.K. Ganguly.
Kalyan.
Dr. Kalyan, sir. He's a senior endocrinologist, Apollo Hospitals. Then we have Dr. J.J. Mukherjee. He's a senior consultant endocrinologist, Apollo Hospital. So the session is all about dialogue and duologue of oral semaglutide. Sir, over to you, Dr. Binayak, sir.
Yeah. So we have got a very strong panel of Dr. Binayak Sinha, Dr. J.J. Mukherjee and Dr. Kalyan Ganguly, and I think it will be a very interesting session because it is all about the oral semaglutide, which is available since last 2 years in our country and which have changed the management of type 2 diabetes and especially the obese type 2 diabetes patients. And so first we will have a discussion, so I'll have 10 minutes each to all the 3 speakers. And then what we'll do, we'll have a discussion and we'll have open discussion. So we'll have more and more insight regarding the oral semaglutide. Now over to Binayak, please. Yes.
Thank you, Dr. Goyal. Thank you very much for inviting me, first of all, to this August gathering. We are going to be talking about GLP-1 receptor analogs, particularly oral semaglutide. And the main focus of the semaglutide will be dealt with by JJ and Kullan. I will just give you a brief introduction into why GLP-1RA and particularly semaglutide are very important in the treatment of type 2 diabetes. Now, we do know that there is an alarming picture of diabetes in our country, about more than 100 million people with diabetes in our country. And if you take into pre-diabetes, it becomes about 250 million. That's huge. And if you take into other considerations like dysglycemia, high cholesterol, obesity, you realize that the total number of people who are suffering from this so-called metabolic syndrome can only be classified as one thing: enormous. And this is a really worrying situation at this point of time, because we know that diabetes and its associated features lead to rather worrying complications, which are microvascular and macrovascular. Microvascular being the eyes, the nerves, and the kidneys, which are far more damaged in diabetes than in people who do not have diabetes. Of course, heart disease is the killer, with a very high increased risk of coronary artery disease, cerebrovascular disease, peripheral arterial disease, and of course, the new kid in the block, heart failure, which we've started to focus on a lot more. Nephropathy, if you go to your dialysis unit, almost every second patient you see there will be a patient with diabetes. Retinopathy, the biggest cause of blindness in our country, and nerve damage and amputation being another of the factors. So we know that this is a problem. How do we control it? Blood glucose control can actually reduce microvascular complications. Plenty of data, starting from the UK PDS, going on to the Accord Advance and VADT, do show that there is a reduction in microvascular complications, which means there's a reduction in retinopathy primarily. There's a reduction in macroalbuminuria, there's a reduction in CKD as well, there's a reduction in neuropathy, which is of course very difficult to grade. What glycemic control does not provide is cardiovascular risk reduction. Or I will just qualify this a little bit and say that glycemic control till today has not been shown to show obvious macrovascular disease reduction. Probably there is some impact. You don't think that somebody who's got a very high blood glucose over a progressive period of time will have a good heart. But as of now, there is no evidence that treatment with any kind of medications will actually, if you reduce the blood glucose per se, it will reduce the risk of macrovascular disease. So, keeping all these things in mind, the guidelines have evolved, and as you can see in 2015, the only thing that we talked about was glycemic control. In 2018, it evolved into CV and mortality benefits. In 2019, it became heart failure and ASCVD. But a real paradigm shift started taking place in 2022 when we started addressing this big little thing in the box, which is the heart disease, which is the kidney disease, which is the heart failure. And the prime drug that came into the focus was SGLT2 inhibitors and GLP-1 inhibitors, GLP-1 receptor analogs. And in 23, it was very clear that now the world bodies are really moving away, whether you talk about the ADA, the ESD, or the American College of Cardiologists. Everybody started saying, forget about glycemic control, first start a GLP-1 or an SGLT2 inhibitor. And in 2024, this was completely reiterated with saying that you manage the cardiorenal problems, and indeed this will also lead to metabolic improvement. If you need anything else, you can add something else, but primarily heart and kidney are the heart of the problem. However, in spite of so much of overwhelming evidence, 60% of type 2 diabetes patients would qualify for a GLP-1 receptor analog. And I'm sure all of you here will agree with me. Obesity, diabetes, heart disease, kidney disease, most of our patients that we see will have these kind of problems. Yet we are not seeing that much of GLP-1 RA being used, and only 10% use it across the world. And in India, it is even lower, 1%. One of the biggest reasons for that is the cost. And of course, there are other problems like injection concern. Most of them have been injections. And also, the non-invasive approach can improve the compliance. And that is why I think the invention of the oral GLP-1 receptor analog, semaglutide, which is oral semaglutide, is known in our country as Rybelsus, has been really a huge movement in the step of, it's a scientific discovery which I think we will all remember for time to come, because oral-based drugs, particularly if they are proteins, go into the stomach and they're destroyed by the proteolytic enzymes and by the acids. There is limited permeability, so it doesn't get very well absorbed. And of course, there is this problem that even if you give these drugs, the bioavailability is very poor, which means that a very limited amount of the drug gets into the circulation. But this has been solved by the scientists who have invented this drug, which is basically semaglutide with change in the B8 position, the amino acid substitution of alanine to alpha amino isobutyric acid. Now, as you know, 4 to 8 is where the DPP4 enzyme works. So replacing the 8 makes the DPP4 enzyme not able to work out here. Again, amino acid substitution has taken place in the 34th position, and this has also made the drug more stable. With that, you have a spacer at the 26th position attached to lysine, which is attached to albumin, which has made it long-acting. Now, what semaglutide provides is a 94% homology with the human GLP-1. So it's almost like what the human GLP-1 is like, and it has a half-life of approximately 1 week. Now, to overcome the problem that was there of this getting degenerated in the stomach, not being absorbed, not reaching the peripheral circulation, what is added is something known as SNAC. So it's sodium caprylate, also known as sodium N-amino caprylate. And what it does is it prevents semaglutide from being broken down and allows absorption, and it promotes the absorption across the gastric epithelium. And these things seem to be working in conjunction with each other like a well-oiled machine, providing the whole of the semaglutide molecule to remain in the circulation, and they are distinct entities. Now, how does semaglutide work? Semaglutide, of course, works by increasing insulin secretion and reducing glucagon, but it also works on the brain, where it reduces appetite cravings, improves control of eating, which in turn leads to reduction of energy intake and also reduction of body weight, but also has other effects across the body with increasing beta cell secretion and responsiveness, reduction of hepatic gluconeogenesis, and lowering of postprandial glucose as well as postprandial triglycerides and lipids. So how do we take this drug? This is taken first thing in the morning on empty stomach with just a half glass of water and half hour of fasting. Please make sure that you take your patients to put the drug in the mouth and then swallow with half a glass. I've had at least 2 or 3 incidents where the patients have actually crushed the drug, put it into half a glass of water, and then swallowed it without any kind of benefit over 3 months, and that's 30,000 rupees down the drain with no effect. So please demonstrate that to your patients. Half glass of water, half hour of fasting, and you swallow the pill when you take it. And this has been tried out in a massive clinical trial program, the Pioneer 1 with placebo, against multiple drugs, and in advanced diabetes as an add-on to insulin, in kidney disease, and has shown CV safety. Of course, to take you through these programs and show what these drugs can do in cardiorenal management, you have two delightful speakers who will take you through. So thank you very much for listening to me.
Thank you, Dr. Binayak, for a nice presentation and discussing how the oral semaglutide works and what is the mechanism behind it. So thank you. Now I invite Dr. J.J. Mukherjee. He is going to discuss about the intervention for obese type 2 diabetic patients with SCVD and what is the role of GLP-1 receptor agonists, and especially can we use this oral semaglutide as a first line drug in our country. As we always say, it is the lifestyle modification, then it comes metformin or SGLT2 inhibitor, or we can now use the oral semaglutide. Yeah, over to you, JJ.
Thank you, good afternoon. Before I start, just to see what's the field like, people who are using oral semaglutide ribulsus in more than 5 patients, can I just see by hands how many of you are using it? 1, 2, 3, 4, 5, 6, 7, 8, very little. But Calcutta has got the second largest number of rich families in the country. It just came out last week. Maximum number of rich families in India live in Bombay, and second, surprisingly, is Calcutta. And still only 8 of us are using ribulsus. Because the only reason for not using this drug is cost. That is the only reason, and the second reason is patients with past history of pancreatitis. And third is the patient can't tolerate the drug. So after today, I think, please try to use it. Ask your patient, why? Let's take, I've got 10 minutes, Varsha. She's 49 years old, I'll go very fast, so please pay attention. Type 2 diabetes for 1 year, HbA1c 8.5, fasting 179, PP2 43, she's obese, she's hypertensive, she's only on metformin 500 BD, she's got family history of type 2 diabetes, CVD, sedentary lifestyle. What is not mentioned here is she's got deep pockets, she can afford drugs. LDL is 122. So what you do is, before you think of semaglutide, before you think of glycemic control, the first thing you should think about is the blood pressure. Get the blood pressure under control. That's where you will get very good benefit. And in diabetics, getting blood pressure control is not easy. You may need 2, 3, 4 drugs. Don't hesitate. Number 2, get the lipids under control. LDL. These are easy shots. Like when you're playing a game, get the easy goals done first. Then come to the difficult goal, which is glycemic control. So now, once you have taken care of the blood pressure and lipids, you're going to do glycemic control. So on the top, 49, female, BMI 30, hypertension, increased lipids you've taken care of, hopefully. Fasting, raise PP, HbA1c 8.5 on metformin 500 BD. Take your choice. I'll give you 20 seconds. Just shout out the number. Okay, I'll send a number. Number 1, how many of you will do number 1? Please respond, otherwise no fun. Number 2, metformin plus phenylurea, how many will do that? Such bolo bhai. All of you will do that, won't you? Metformin plus SGLT2. Okay, couple of hands are going up. Okay, thank you, sir. Metformin plus GLP-1 RA. I told you she's got deep pockets. She comes from New Alipur. Yes, okay. So metformin plus DPP-4. Metformin SGLT2 plus DPP-4. Now metformin SGLT2 plus GLP-1 RA. That probably is the best option, isn't it, if you can afford it. So if you see, this is the ADA-ESD guideline. You must have seen it 100 times. This is the latest one, 2018, which comes out as ADA standards of care. 49, BMI 30, hypertension, increased lipids, HbA1c 8.5. She straight away falls into the high-risk group. If you go to semantics, actually she doesn't. She doesn't have ASCVD, she doesn't have heart failure, doesn't have CKD. I did not give you the CKD values. Let's say they are normal. She comes onto this second box, indicators of high risk. The age cutoff there is 55, but then 49 female with all the others, hypertension, obesity. I think she's at high risk. So what is the role of GLP-1s? Now all the GLP-1s available are listed for you there. The 8 GLP-1s available in the world. And the ones which I have ticked are the ones which are commonly used. I don't know how many of you are still using liraglutide. Anybody still using liraglutide in this room? No. Dulaglutide, Trulicity once a week. How many people are using it? Couple of you. And of course the last one is oral semaglutide. Yes, sir. So these are the various ones available. The interesting part is, this is the most expensive molecule. Very few of you are using it, but 5 out of 8 available in the world are available in our country. So isn't an oxymoron thing like exenatide is available, lira is available, dula is available, sema oral is available. So 5 of the 8 GLP-1 receptor agonists available in the world are available in India. And of these 5, just see the green boxes: Leader, which is liraglutide; Sustain 6, which is subcut semaglutide once weekly; Harmony, which is albiglutide, which is not available anywhere in the world. The Glaxo took it off. Rewind, which is dulaglutide; and Amplitude O, which is not even licensed anywhere else. These are the only GLP-1 receptor agonists which have got cardiovascular benefit demonstrated. That is, they were superior. So now coming to Varsha's glycemic control. So if you add semaglutide, to me, the first drug should be metformin, and the second drug, if there is no contraindication and deep pocket, should always be a GLP-1. I'm not saying it because this is a sponsored meeting, because GLP-1 molecules have got a lot of benefits. Let's see. Look at the HbA1c reduction. Oral semaglutide, 14 milligrams, HbA1c less than 7 in 83% as opposed to placebo on the metformin background. HbA1c less than 6, weight loss more than 5%, about 1 in 3. Coming to weight loss of more than 5%, it's not a weight loss drug. Oral semaglutide is not a weight loss drug in the dose that we are using, 7 and 14 milligrams. To have weight loss, we need much higher doses, or we need the injectables, 2.4 milligrams subcut once weekly. But even then, more than 5% weight loss, if you see all the pioneer trials which Dr. Binayak Sinha mentioned, Pioneer 1, 2, 3, 4, if you see roughly about half the people are losing about more than 5% of weight, and 20% can lose up to more than 10% weight. Not only weight, the most important thing for Indians is the waist circumference, and that also comes down by about an inch or inch and a half when you're using oral semaglutide. It reduces systolic blood pressure. I'm not selling that it's an antihypertensive. Please no. You need to use antihypertensives, but it also has added benefit of reducing your systolic blood pressure by 5 millimeter. Now 5 millimeter may be a bit of an oversell depending on which clinical trial you're seeing, but anywhere between 3 to 5 millimeter mercury drop in systolic blood pressure. It improves blood lipids. Again, please don't think that I'm selling it's a lipid lowering drug. Of course it's not. But what it's trying to tell you is does not do any harm to the lipid parameters. Does it decrease LDL triglycerides significantly? Yes, statistically, but in day-to-day life it doesn't. But anyway, you keep that in your pocket. It reduces vascular inflammation. CRP is a biomarker of CV risk, and it was studied in the various pioneer trials. It reduces CRP level. Oral Sema versus EMPA, this was Pioneer 2 trial. I mean, those who were interested. So there is a reduction in CRP. Now, regarding cardiovascular benefit, before you ask the question, oral semaglutide does not show superiority in 3P MACE as of now, because the initial trial was done only for registration of the drug. It was not a dedicated cardiovascular outcome trial. A dedicated cardiovascular outcome trial is happening, but the injectable weekly semaglutide, which is Sustain 6, if you can see, unequivocally, statistically significant 26% reduction. And what does the company do till they get the sole trial? They combine both. They combine the oral semaglutide and injectable semaglutide, and they do a meta-analysis, and they tell you that yes, there is a statistically significant 24% reduction in 3P MACE. 3P MACE is non-fatal MI, non-fatal stroke, and cardiovascular death. That is the endpoint in all cardiovascular outcome trials. Now, reduction in cardiovascular and all-cause mortality in the Pioneer 6 trial, this was not statistically significant, but there's an indication that there may be reduction in cardiovascular and all-cause mortality, but we need to wait for this trial, SOUL trial. You'll be hearing Binayak, Kollan, Ghanshyamda, me coming and talking to you about SOUL trial, provided it's positive, isn't it? Again and again, because SOUL trial is oral semaglutide, which is looking at the cardiovascular outcome trial in 9,500 patients. Huge trial. They're spending billions on this. And the outcome, if you see, is, what is it? 3P MACE again. 3P MACE is non-fatal MI, non-fatal stroke, and cardiovascular death. Whether it's going to be positive or not, time will tell. But having said that, if you saw the meta-analysis before, most likely, but we cannot conjecture. Does oral semaglutide only cause blood glucose control? No, it does much more. As you can see, improves glucose control, reduces UACR and EGFR. This is going to become the 5th pillar in the renal management. It's not there yet because the data was not available. It just got published, the FLOW trial. Maybe we'll be discussing it later. Improves lipid profile, maybe little bit. Chalo. Reduces blood pressure, little bit. Reduces CRP, yes, and reduces body weight. So one molecule, previously we used to have 2-in-1s, isn't it? When I was a student, when I first bought my 2-in-1, it was so exciting. Radio bhi hai, cassette bhi bachta hai. Now this is 6-in-1. So what more do you want? So Oral semaglutide is now approved for first-line management of type 2 diabetes. First line is always lifestyle, lifestyle, lifestyle. Don't forget that. Diet, exercise, diet, exercise, diet, exercise. And then, generally speaking, most of us in this room probably will be using a metformin. And after that, I think it should be a GLP-1, not less than below 18. You can't give it to 12, 13, 14, 15 years. Monotherapy, you can use combination use, special populations, people with renal impairment, up to GFR 15. Hepatic impairment is always a Pandora's box, but up to child B, I will be happily using it. It's cardiovascular safe because there's non-inferiority as to whether it's cardiovascular benefit. We need to wait for the SOUL trial. Now, this is the real world data being collected from India. The data will come out. Demallo is the primary investigator. So oral semaglutide has been well accepted as the preferred drug for managing early diabetes in India. But this is in people who can afford and who have chosen to go on oral semaglutide. And you see 90% was started for achieving better glycemic and weight control. 30 seconds, sir. 8.9 was the baseline HbA1c. 1 in 2 had CVD-related history, and 1 in 5 were started on oral semaglutide within 1 year of diagnosis. So coming back to my initial thing, which will you start, many of you would have chosen metformin GLP-1, metformin DPP-4 if they can't afford GLP-1. The next 5 slides are basically trying to sell metformin, SGLT2 and GLP-1. Do we have a randomized control trial yet? Looking at hard endpoints, we don't. We have a lot of prospective data, a lot of retrospective data. The next 5 slides I can just summarize in one line, and that's what I will do, which is benefit of dual therapy with GLP-1RA and SGLT2 on cardiovascular outcomes in people with type 2 diabetes. Just see the green bars, GLP-1 and SGLT2 when they combine together, heart failure, almost statistically significant 7% reduction. If MACE, 3P MACE, major adverse cardiovascular events, GLP-1RA and SGLT2, statistically significant reduction, all-cause death, significant reduction. So, greater all-cause mortality benefit with combination therapy. So as we started, and I think all of you in the beginning agreed as well, that in this lady, just look up again, 49 years old, female, obese, definition of obesity is 25. In this room, 70% of you are obese, including me. My BMI is also just 25.1. So don't think that you're not obese. And if waist circumference, if you're a male, just see what is the belt size. I'm obese. So 80% of us are obese in this room. So obesity definition is very strict, more than 25. Hypertension, lipid should control. Fasting PP is high. My choice here would be metformin, if she can tolerate 1000 BD, SGLT2 and a GLP-1RA. But if she says I don't have the money, then I would go for metformin, SGLT2, DPP-4. Don't hesitate in asking once. You'll be surprised. You will be pleasantly surprised. I have been surprised. But I don't tell GLP-1 for a while, then the third or fourth visit, I say, একটা ওষুধ আছে মাসে 8 থেকে 9000 টাকা যাবে ডাক্তারবাবু আগে বলেননি কেন না আগে বলেননি কেন মানে আপনি পারবেন কি আছে 9000 টাকা তো but that is not everybody but 1 in 10 you will be surprised. So with that I'll stop. Over to you, sir.
Thank you, JJ. I know time was very short, but you are absolutely right in giving the message. So thank you very much. So now I invite Dr. Kalyan Gangopadhyay. Kalyan is going to discuss approach to a case of type 2 diabetes and CKD in a patient on insulin. As he's having recurrent attacks of hypoglycemia, as we all know, these CKD patients are more prone to have hypoglycemia. So what else? This is the GLP-1 analogs, it's the oral or what? So now over to Kalyan.
Okay, thank you, Ghanshyamda. So I'm going to talk, because this is about semaglutide. So semaglutide in CKD. Now, so this is a hypothetical case of a lady with HbA1c of 8.9 and GFR of 57. The original slide was 60, so I had to tweak it down to 57. Otherwise, there will be controversy whether she's labeled as having CKD. Now, how do you approach? Now, this is an incomplete slide. Where is the lipid profile? Where is the blood pressure? Where is the urinary ACR? So it's incomplete. So nobody should ask a question, what will you do? Give me these answers first. And for this lady has got CKD, the chances are that she is going to die from heart disease or cardiovascular causes is much more than the chances of her dying on the dialysis table. So attempts, 1, to prevent cardiovascular death, 2nd, to prevent the kidney disease from progressing. Now, actually, in the anti-hyperglycemic agents, there are only 2 drugs which have been trialed in CKD. One is canagliflozin and one is semaglutide. CKD, type 2 diabetes. You might be surprised, what rubbish am I talking? Where is EMPA and DAPA gone? The EMPA CKD, DAPA CKD were there, but there was a mixture of type 2 diabetes and non-diabetic patients. So pure type 2 diabetes with CKD, it's only semaglutide and canagliflozin. Now, so CKD is common. It's an independent risk, increases mortality and morbidity, this all we know, and is a risk factor for hypoglycemia. So that should be kept in mind. Sugar drop nahi hone dena hai. So patient is on insulin, and if you add semaglutide, so this has been there for all GLP-1 receptor agonists, and I have used several patients on insulin, added semaglutide, and there is a very salutary benefit in reducing the insulin dose and the HbA1c. So here you can see this trial was dedicated just for these type of patients requiring at least 50 units or more of insulin. So if you add semaglutide, so these patients, you have tried your best by giving insulin to get the blood sugar down. The patient is taking an average of 58 units of insulin, and still you haven't achieved the HbA1c. Now you have added semaglutide. So you get 60% of patients who achieve target, there's no body weight gain, and hypoglycemia event is similar. You might say, "Arey, hypoglycemia to কম হওয়ার কথা," but hang on, আমি তো HbA1c অনেকটা কমিয়ে দিয়েছি। তো কমালে পরে there will be more hypoglycemia. That is not occurring. So remember. Then HbA1c, so 1.3. So you have to remember, this is not just a patient dropping the HbA1c by adding semaglutide. This is the patients on insulin, and the doctors have tried to get it down, have not achieved. Now you're adding it, now you're getting it down to 1.3. And on top you have lost about 4 kilograms of weight. And the dose requirement of more than 20%, so about a third of the patients, they require 20% less insulin. Now, there are potential mechanisms by which GLP-1 receptor agonist is going to work. Remember, CKD patient type 2, I will first think about SGLT2. I will not think about GLP-1 first. That should be rule number 1. So, SGLT2, patient is already on. Now, what next? So, GLP-1 works very slowly. SGLT2 for heart failure at least works very quickly. But GLP-1, everything, CV, death, renal, everything works very slowly but surely. So you've got multiple mechanisms. Natriuresis, JJ had mentioned about blood pressure drop as well, reducing kidney and systemic inflammation, oxidative stress, a lot of things. Many drugs reduce albuminuria. So if somebody tells me this is a wonderful drug which reduces albuminuria, does it stop the GFR from going down? No. And then what's the use? You have to tell me that it does both. So for CKD patients, there are 2 trials with semaglutide. One is Pioneer 5, and the other one dedicated for renal outcomes is the FLOW trial. So this was the first trial with semaglutide in patients with CKD GFR between 30 to 60. There, they wanted to show whether it is still effective in reducing the HbA1c and still affecting in lowering the blood pressure. Now remember, patients when they develop CKD and you use anti-hyperglycemic agents, they don't work that well. Why? Because SGLT2 will not work that well, works primarily to the kidneys. Sulfonylureas, because the CKD occurs when the diabetes has progressed for a while. So therefore, the efficacy would be, at least theoretically, should be less. But here you can see it still drops by more than 1%, the HbA1c, in patients with eGFR 30 to 60, and still drops the blood weight by more than 3.5 kilograms. So the effectivity of the oral semaglutide is maintained. Now the KDIGO guideline does incorporate GLP-1 once you have exhausted the blood pressure lowering agents, including RAS blockade and diabetes medications, including SGLT2, and next step, GLP-1 receptor agonist. This is the FLOW trial. So because before the flow trial was announced, I had said this will be a make and break trial for semaglutide. If it's a failure, then a chapter will be closed for GLP-1 receptor agonists of CKD. But fortunately, they passed. So this was patients with CKD. It's important to remember the inclusion criteria. HbA1c less than 10, eGFR more than 25. That's all you need to remember, more than 25. So on background RAS blockade. So you give semaglutide and period. But there are important, interesting things in the flow trial. Because one might argue, I mean, you have just said that it is a very, very robust HbA1c lowering agent. তাহলে HbA1c কমিয়ে দিলেই তো নেফ্রোপ্যাথিটা কমে যাবে. I'll come to that. So we have got about more than 230 patients from India. So the first composite outcome, that is persistent drop in GFR of more than 50%, onset of GFR, that is end-stage kidney disease, start of dialysis, renal death, CV death. So this whole thing was reduced by statistically significant 24%. So this was over a median time period of about 3.5 years, if I'm not mistaken. So you can see here, the graph begins to separate about 12 years time, 12 months time. So it begins to separate at 1 year. Here, this highlights the slow working nature of the GLP-1 receptor agonist. So it separates and it maintains that. So that's the eGFR going down. Now the important bit. So here is the body mass index, because that's a commonly asked question. Patient যদি মোটা না হয় তাহলে কি কাজ করবে? So eGFR, BMI less than 30, more than 30 works, because p-value for interaction was not significant. Duration of diabetes. So if it is more than 15 years, then also it works. And in fact, actually it looks better than less than 15 years. So now the other question was, যে সুগারটা কমিয়ে দিলেই তো ওটা ভালো হয়ে যাবে, তো ওটার জন্যই হয়েছে বোধহয়. So if you look here, less than 7% HbA1c, there also it works. So it is not just the glucose lowering, this is the final statement. It is not just the glucose lowering ability, it is something they are doing to the kidneys which helps. Because HbA1c less than 7%. Remember, if this group had a mean HbA1c of 11%, then I would have said a lot of cloud in there. It's a cloudy, muddy water. So again, eGFR 60, more than 60, less than 30, ACR less than 300, more than 300, everywhere there is benefit. So there was a 24% lower risk of composite primary outcome, consistent risk reduction of kidney components, 18% lower risk of CV death, so slower reduction of kidney function by a mean eGFR of 1.1, and overall death. So this is something, the patients that খুব ভালো এটা হিট হয় যে রিডিউসিং আপনার মরার চান্স 20% কমিয়ে দেবো, আপনি অ্যাস্ট্রোলজারের কাছে গিয়ে আংটি পরেও পারবেন না সেটা করতে, সেটা একটা করে দিতে পারবো. So that we can say. So now the important bits. So Asians were about 27%. Now you see the mean HbA1c 7.8. I'm so glad that the mean HbA1c was lower. I repeatedly say this. Less than 7% HbA1c, actually 1,100 patients had HbA1c less than 7%. Okay, I'm almost finished. And diabetes more than 15 years was 60%. eGFR less than 30 is also 12%. Unfortunately, only 15% patients had SGLT2. So therefore, we cannot make any comment as to, although the graph did show that whether it's on SGLT2 or not, the benefit is still there. So I think that's my last slide. So direct and indirect nephroprotective effects. Even in presence of CKD, there is robust HbA1c reduction. Even in presence of CKD, there is weight loss. And particularly in patients who are on insulin as well, there is a total dose reduction of 20%. So now I think slowly, there is another drug in the armamentarium in patients with type 2 diabetes and CKD, which is going to help patients from landing up on the dialysis table. So with that, I end. Thank you.
Thank you, Kalyan. Please take your seat. So give a big hand to all three speakers or panelists for giving overview of semaglutide. And as Kalyan have discussed, as we all know, if the EGFR is more than 30, start with lifestyle modification mandatory, then metformin, then you can go for SGLT2 inhibitor, and then definitely GLP-1 analog and the oral semaglutide one of the chance. And because the biggest advantage with the oral with the GLP-1 analogs is you can use up to the EGFR 15. That is very important. While in case of SGLT2 up to 20 now, the KDIGO guidelines say, otherwise it was 30. So that is it. So first I'll ask the one question each to my panelists. No. Achha. I'm going to ask one question each to my panelists, and then the house will be open for discussion. I think it will be around 20 minutes discussion, and then I'll wrap up within 2-3 minutes. So to Binayak, why it is more difficult to lose weight among patients with diabetes as compared to people who are not having diabetes? Yes.
I think the reasoning is pretty simple. I think diabetes is characterized by polyphagia. So people with diabetes tend to eat more than necessary, and that is one of the reasons it's very important that the appetite is curtailed in people with diabetes. And if you speak to people who are putting on weight, and if you speak to their family members when they are not around, you'll always get a feedback saying that yes, this person has been eating a lot, and we've been trying to curtail this. So that is one of the things. Secondly, lifestyle. I think the main reason is lifestyle, and this is due to a complex interplay of hormones, because insulin secretion is increased in type 2 diabetes, and that itself is a trigger for hunger, and all these things conspire to make people more and more obese and more difficult to lose weight in these people.
One of the important aspect, I think all agree, is the drugs which causes weight gain.
Yes, of course.
Sulfonylurea, glitazones, all these, that is one. And second, the protective snacking. Because once a patient who had faced or experienced hypoglycemia, even it is level 1, forget about level 2 or level 3, he will try to go for a protective snacking. That also causes. Yeah, now this is the question to the JJ. What are the current strategies you adopt in your clinical practice to reduce the CV risk in your diabetic patients?
Me?
Yes.
Okay, so reduce CV risk, first and foremost, assess CV risk. Every type 2 diabetic patient who comes to you has got very high CV risk. If they don't have any symptoms, just a routine 12-lead resting ECG is more than enough. But when I presented, I showed you people with high risk. Age more than 50, if they have any 2 risk factors, obesity, hypertension, hyperlipidemia, that are high risk. So you have to intervene. So what do you do? As I said, I already presented this. First and foremost, get your blood pressure control, blood pressure control, blood pressure control. Get lipids control, lipids control, lipids control. And then get glycemic control. When you do glycemic control, that's what we are coming to now. Use drugs which have got cardiovascular protective effect. Basically, you have, if they are obese, then metformin has data. UKPDS had 342 patients in the arm where metformin reduced cardiovascular. That was in fact the first drug which showed 3P MACE reduction. That was metformin in obese group in the UKPDS trial. Then it's the SGLT2 inhibitors we all know in this room. And now the GLP-1 receptor agonists. When I was presenting, I told you that amongst the ones available to us, liraglutide, dulaglutide have got 3P MACE benefit. Oral semaglutide as of now has got non-inferiority data, not superiority data. But I told you the reason why that is so, and I also told you that once weekly semaglutide has got 3P MACE benefit, so possibly, but I cannot count stars, oral semaglutide also probably would have. So basically, lifestyle modification, glycemic control, blood pressure control, lipid control, and the last thing, which is very important, is to get them off tobacco. Get them off tobacco.
Yeah, in one of the studies we have shown around 50% of the patients who were on oral semaglutide, they have got a weight reduction of up to the tune of more than 5%. That is around 45%. So that is an added advantage, because we all know each and every other patient of diabetes is obese. even in our country. Our definitions are of course different than what is there, but it more than or any other, every second patient is obese. So in that situation, subset of patients, it is definitely beneficial. Now question to Dr. Kalyan, what is your experience of the oral semaglutide in reduction of A1C and weight loss? As I think in this hall, a lot of my colleagues are using the GLP-1 based therapies. We were well versed with the injectables. Initially it was exenatide, then liraglutide, and of course dulaglutide once weekly. Exenatide not very well once weekly, but now oral semaglutide we all know, so we are using. So what is your experience in clinical practice, and when you'll say that suppose in patient who is not getting any benefit of weight reduction, you have started with 6 months and patient is not having any benefit in the weight reduction, so how will you proceed? You will continue to have the extra glycemic benefits, or you will discontinue? What is your take home, and please?
Okay, so we are not talking about trial, it is my experience you're talking about.
Yes, not
So
the trial.
I
I
think
want real world
Okay.
evidence, real world studies.
So
Your personal
roughly, there is concordance between the trials and what I have seen.
Yes.
So 3 milligrams of semaglutide is equal to a DPP-4 as far as HbA1c reduction is concerned, around 0.8. Weight loss around 1 kilogram. 7 milligrams of semaglutide, I think it's around 1.3, 1.4, bordering around that area. Weight loss around 2.5 kilograms. Once I give, and this is I've clearly noticed, once you jump from 7 to 14, there is a big jump in drop in HbA1c. It was about 1.8, many cases it is about 2.5, and weight also 4 to 5 kilograms. That's a mean I'm saying. Some patients respond very well, some don't. So
You
because
call that group as a super responder,
yes,
or it's
so some
generalized?
correct. So some patients will be super responders. I will be the richest person on earth if I can unearth as to which patient is going to be super responder, and that is the one I'm going to give. So
Yes.
unfortunately, I don't have that astrology calculation in my mind yet. So I think when the patients ask, this is a costly molecule, is it going to work for me? So I said there is this 80% chance that it will drop your HbA1c or your weight, and both. So then your question is 6 months, there is no weight loss. So this is primarily an anti-diabetes, anti-hyperglycemic agent. So I will tell the patient, look, you are looking at the weight, I am looking at your HbA1c, I am looking at your future death from heart and from kidneys. So if there is no weight loss, but there is very good reduction in HbA1c, so I will say carry on. If there is none, no HbA1c drop, no weight loss, it will be very difficult for me to continue.
No.
So 6 months, if
I'm interrupting you.
Huh.
As you have discussed, no A1C reduction. In that situation also you will continue?
so then also there is the weight loss benefit will be there. It is those patients will be very rare. They are probably not taking the drug
Yes.
correctly.
Yes.
I've seen inpatients being started on Ribelsus. They've just written 3 milligram before breakfast. That is not how you start. So that's not how you start. So 6 months patients ask, how long should I continue? My weight loss is not happening. So majority of the time the weight loss, whatever has to happen, should start before 3 months. If there is no weight loss for 6 months, there are some anecdotal reports that beyond 6 months also there might be some weight lowering efficacy.
Yeah, sure.
My one line to this is, if you're starting Ribelsus, don't start it as a weight loss drug. Don't
is
tell your
not-
patient you're giving Ribelsus for weight loss.
It is not approved for weight loss. It
And
is
not
approved
at this
for,
dose.
Yes.
At this dose, you will get, I showed you, about half of them will have 5% weight loss. 10% will have more than 10% weight
10%.
loss. But other half will not have, na? So if you're starting Ribelsus in a diabetic, telling ki vajan ghata dunga, vajan nahi ghata, and the patient stops Ribelsus, he misses out on all the other benefits of glycemic control, cardiovascular benefit, renal benefit, all that is gone. Because patient's mind was, I have to lose weight because with this drug. So you can say,
This is the question to Vinayak.
So can I just come in here for a second, Kanchamda? I have a question for Kullan. So Kullan, actually only 13% of people actually manage to graduate to the 14 milligram dose. So do you think that 7 milligram is really such a innocuous dose that it's not providing that kind of benefit?
Difficult to know because the trials have been with the maximal dose. So whether 7 milligram would get at least most of the benefits which the 14 milligrams, I don't know. I'm presuming it would because it's the same molecule, but I don't know the answer. But the bottom line is that 7 milligram has got the HbA1c down between 1 to 1.3%. It will have some effect on the blood pressure lowering as well. So at least if not for weight, for as an HbA1c lowering agent, it will still work. And there is another area, NFLD or MFLD. Two of the GLP-1 molecules most researched is one is liraglutide and one is semaglutide. That's very good effect on MFLD, which none of the SGLT2 inhibitors don't have that wealth of data for MFLD as the GLP-1 receptor agonists have.
Only MPI is having some data regarding the MSLD. Yes, and I lived. And Binayak, I've got a question for you. You have used both injectable dulaglutide and oral semaglutide. So how you make a difference? Is it both are same or is there any difference? What is the benefit over, suppose you have got a choice, a patient, you have given a choice of injectable dulaglutide once weekly or oral semaglutide once daily. It is not the question of injectable or oral. So is there any extra added advantage, CV safety, CV benefits, heart failure? Of course, we know more with the SGLT2 inhibitor than the GLP-1, than regarding the CKD benefits and all that. In this out of these two, in which subset you will choose, this oral or injectable?
So it's first of all a choice between for a patient, and secondly, I am a bit of a conservative. If somebody has a history of heart disease, say somebody's had a myocardial infarction recently, I would go with dulaglutide still. Because as of now, we don't have any obvious data with oral semaglutide.
Yes.
We have it with injectable. And you can argue that the injectable, since it has it, the oral one will also have it. And if I were to put my money on it, I would say yes, the SOUL trial will be a very strong and resounding success. But if you ask me today, the first offer that I would make would be the injectable dulaglutide in patients with documented coronary artery disease or stroke. And indeed, if you look at the kidney data, the data with dulaglutide is also quite good. Dulaglutide also, it's not a trial which was designed to look at kidney, but it has shown very good. The similar kind of benefits that was shown in the FLOW trial have been shown with dulaglutide as well.
So benefit is especially if somebody don't want to have a prick, then you can give the oral.
Absolutely.
Yes.
Absolutely.
Yeah. So now the session is open for discussion. Yeah, Dr. Govind. Can you give mics, please?
Water. But I've got quite a few of my patients who keep visiting Singapore. There the doctors in Singapore had advised them to switch over from early morning to bedtime. And still they are continuing, the patients are quite medically, they follow the medical field on the Google. So they had argued with the doctors over there also. But they were still told, no, we have told you take it at bedtime, so take it at bedtime. What is your take on this?
So I think you can safely tell them that the doctor in Singapore or doctors in Singapore, whatever they're advising, that is incorrect. There is clear evidence. Remember, the absorption is less than 1%. You have to be very, very clear about this. We are obsessed with giving thyroid tablets, empty stomach, telling the patient, in empty stomach, thyroid tablets, 80% is absorbed. If you take in a full stomach, 60% is absorbed. And here is a drug which is 1% absorbed. You have to be very, very clear. It has to be empty stomach and not at 11 p.m.
Sir,
at night.
the patient's HbA1c has reduced.
Just a minute. Because if you have seen, Binayak have shown one slide during the mechanism of action of oral semaglutide. At that time he have shown, if you have taken the empty stomach, 3 milligrams, 7 milligrams, 14 milligrams, the drug levels of semaglutide. If you have taken postprandial, it was just 0 or 1% absorption. So we have shown the slide if you have seen it properly.
So the
it should be
patient's,
given empty stomach, empty stomach.
So the patient's HbA1c has reduced from 8.4 to 6.8.
Yeah, I heard that and I'm coming to you. Maybe the patient is taking after 4 hours. Since
Bedtime.
Singapore, they have their dinner by 7:38 is the dinner time.
Dinner is at 8 and bedtime is at 12.
And suppose they're taking at 12, so it almost becomes empty stomach. But in India, when you're spending so much, better take it the right way, na?
There is one question, but at times because the thyroid medicine is taken in the morning, that has been asked to be taken at night.
So that precisely. So thyroid medicine, if you have a 4-hour gap, that is enough. So Davidson's textbook says thyroid tablet should be taken at bedtime. That's because they have their supper at 7 p.m. and go to sleep at 11 p.m. We don't. But thyroid, you see, as I said, 80% in empty stomach and 60% in full stomach. So you will have a reduction of only 20%.
But in case of semaglutide, it is
In case of
very low,
semaglutide,
not at all. It's only
1% absorption. If patient is on both medicine, two options, either after half an hour you give thyroid tablet and then wait for half an hour, but most people in Calcutta, they want their cup of tea in the morning, so they can't wait. So the other option is take it, but I tell them, before which meal do you have a 4-hour gap? You take half an hour before that meal. It can be at bedtime, it can be before dinner, it can be before lunch.
Yes, sir. Please give the mic.
4 बजे खाना खाता है, सुबह एम्प्टी स्टमक कैसे रहेगा?
क्या सर?
अगर रोजा कर रहा है कोई और सुबह 5 बजे खाना खा रहा है, तो 6 बजे एम्प्टी स्टमक कैसे रहेगा?
नहीं सर, 6 बजे तो लेगा
तो
नहीं
यू
ना, सर।
टेल एम्प्टी स्टमक 11 o'clock 4 बजे, अभी 4 बजे शाम को खाना खा लेंगे, 11 बजे तो एम्प्टी स्टमक हो जाएंगे ना.
So I think there is no end to this debate.
Yes.
Then I will say, what about night shift workers? There is no end to this debate. But sometimes we have to use our common sense
Yes.
also.
Actually, the studies and everything have shown, as Kalyan have mentioned, if you take full stomach, it's 60% in case of thyroxine and 80% if you take empty stomach. But in cases of especially the semaglutide, oral semaglutide, it's 1% only, and while it is 90%, more than 90% absorption. So remember, it's very important, you have to take empty stomach. That is very important.
No,
The message is
Ganchabla,
clear.
these are practical questions.
Yes,
actually.
definitely. Fully
Because
agree with it.
what he asked about the Roja also
Ramadan.
applies to night shift workers. That what, sir, you are saying that. Correct. So we go. So I think for empty stomach for thyroid. So remember, a rule of thumb: thyroid 4 hours, for this 6 hours.
6 hours minimum.
Bas.
Yes. Minimum 6. Any other questions? Yes.
My question to Kolanda. Kolanda, in your case, you have put the patient on oral semaglutide, and the data which you have taken, the renal benefits, that is from the SOUL trial. But it is on the
flow.
Flow trial.
Flow.
Trial. It is on the injectable semaglutide.
Correct.
So we do not know that whether that benefit will be there with the oral semaglutide, because otherwise the sustain 6 is enough. Why we need a SOUL trial? And second thing is that not only with the GLP-1 analogs, but also with the SGLT2 inhibitor, the meta-analysis of the trial has suggested that the higher the proteinuria, better is the renoprotective or the cardioprotective benefits. What may be the possible causes?
So I think higher the proteinuria means higher the inflammation. So I think here as well, if you look at the graph, it seems that the higher proteinuria seems to be working better. So if higher the proteinuria, I think is higher the inflammation, so better it will work. That is what I feel. That is the bottom line. And if you're right, that's injectable. But I think there are now 2 big trials which have come up with oral versus subcut, which has got very similar HbA1c drop and very similar weight loss, if the oral is taken properly. So one can assume that we can extrapolate these results to that. But you are correct, subcut, this is with subcut, and what we are discussing, one is oral.
And another thing is that, do you think
I think,
that
Sandeep, you can discuss during the tea time. So I think we should not cross the time. So first, we have got a new molecule, that is the oral semaglutide. Since last 2 years we are using, and everybody is having a lot of experience regarding this particular molecule, and this is a good add-on in the armamentarium in the management of type 2 diabetes. That is there, and all the pros and cons and about the CV safety, renal benefits, each and everything has been discussed by all the panelists. So please give a big hand to all the panelists. Thank you very much. Now to the organizers.